Hey, welcome back, everybody. It's time once again for another episode of Living Hope, a show designed to give you hope, inspiration, and education from those actually working in this field and those actually living with pancreatic cancer. Sharing the real-life stories of those really affected by this deadly disease and how they deal with it on a daily basis, along with the experts like we have with us today who are going to tell us more about what's happening in this field. From the woman who's sort of become a pseudo-expert. I don't know. I don't have a degree, but you seem to know a lot, Roberta Luna.
Thank you. Actually, my doctors have given me an honorary.
Is that it? Okay.
I'm an honorary doctor.
21 years survivor. I guess you picked some up honorariums along the way.
Yeah, I know a little bit, maybe, but it changes, which I'm really happy to see that it is changing. But today we have Dr. Kim Reiss with us. She is an associate professor of medicine in the Division of Hematology Oncology at the Abramson Cancer Center at the University of Pennsylvania, with a research focus on improving outcomes for patients with pancreatic cancer. Dr. Reiss is a member of the Scientific Advisory Board for Let's Win Pancreatic Cancer, and her medical expertise is in treatment of patients with the BRCA-related pancreatic cancer. I think that's a mouthful, and that was only just a part. You really have.
The show's over. Unfortunately.
Yeah, unfortunately,
we're out of time.
I only have a little bit of time, so I was trying to get everything in there, but it's very difficult. But I'm very honored and impressed to have you with us. And first, if you could start off, I know a lot of people are going to ask, what is the BRCA? So if you could maybe just give us a little bit on an explanation for that.
Sure, absolutely. The BRCA gene is something that we all have. We all have 2 copies of the BRCA gene. And the BRCA gene is responsible for making a protein that helps with DNA damage repair. So when there is breakage of DNA strands, specifically double strand break, so when both strands break at once, which can happen with toxin exposure, chemotherapy exposure, other exposures, the BRCA protein, which is created from that gene, repairs those breaks. And so those who have a BRCA mutation, people who have typically one of them is out. So we have 2 copies of the gene, but if one is mutated or, broken, busted, then those individuals have a higher lifetime risk of getting cancer.
And is that just in one type of cancer, or do you find that in various types of cancer?
It's various types of cancer. People typically, the BRCA gene was named, it's breast cancer. It's BRCA, breast cancer gene. And that's what it was initially associated with. But individuals with this syndrome of having a BRCA mutation can be afflicted with a number of different cancers. We commonly think of breast and ovarian cancer. And even now in my clinic, people say, my son is not going to be affected by this, right? Because if he has BRCA, he's not at risk. And that's actually not true. First of all, men can get breast cancer if they have the BRCA gene. But BRCA is also associated with prostate cancer, with melanoma, and of course my work, very importantly, associated with pancreatic cancer as well.
Now, the process in treating pancreatic cancer has been very slow. Could you elaborate on the unique challenges that pancreatic cancer presents to researchers and clinicians?
Absolutely. Pancreas cancer has a number of features that make it really difficult to treat. One of them is simply that we lack good ways to identify this cancer early in a general population. And so by the time patients are identified as having the disease, they've often been through months of evaluation, or they show up without the diagnosis is often caught late, basically. So they may have shown up with some belly pain or some back pain or something that mimics all these other very benign disorders like acid reflux or simple back problem. And so they often go a long time without knowing that they have the disease, or they just have no symptoms and show up in clinic and already have late onset disease. So the fact that it is uncommon to catch the disease in its most early stages is a big part of the problem as we try to tackle it. The second is that once patients come in and they've already had the they have the diagnosis and they're late in their course, they're often very sick from this illness. You're nodding. I think you know that. Once the disease sort of takes off, it's a very symptomatic cancer because it's a digestive system cancer. So people have a hard time with nausea and with diarrhea and with pain with eating and weight loss and stuff. And so once you get someone into the clinic in front of you, you have to be able to treat them. So you have to really focus on trying to build the person up and get their nutrition built up and everything to try to get them into treatment. And then the disease itself is incredibly aggressive. It's fast moving. And it has a sort of shrink wrap around it. We call it the stroma, which prevents chemotherapy from even penetrating into the disease, into the tumor bed. So for many reasons, it's an aggressive and difficult to handle disease.
Yeah, my dad was diagnosed with it, and it took them 6 months to diagnose it. And then
Yeah.
once they found it, he was gone in just a matter of weeks, and it was really
Yeah.
difficult. Yeah.
It's awful, awful because you get it and you don't even have an opportunity to get treatment because you're already so unwell by the time you're diagnosed. It's a big problem.
Yeah, exactly. What inspired you to focus your career on pancreatic cancer, especially because the odds, I mean, it's not that any cancer is good, but the survival rate for pancreatic cancer is one of the worst. So what
Yeah,
what brings you here?
Two things. One, my own father, he was an oncologist, and so I sort of grew. He was not a pancreas cancer oncologist, but I grew up sort of hearing stories about cancer around the dinner table as a child. So I think that really motivated me to take care of that same type of population. And truly, it's my interest. It was my interest in genetics that really steered me to this disease. I have loved genetics since I was in high school, then through college and through medical school and residency. And so we knew by the time I was graduating from my training that the BRCA gene was associated with pancreatic cancer, and I really wanted to study a genetic disease. And I found the Vassar Center at Penn, so I interviewed at University of Pennsylvania. I wasn't there for training, I was at Johns Hopkins, and so I found the Vassar Center as the only national center completely devoted to the study of BRCA-related cancers. So I came up to Penn to interview. They had a job for a GI oncologist. And I met with, as part of that interview, I met with Susan Domchek, who as the director of the Vassar Center. And she said, we don't have a pancreas person. And I was like, sign me up, I'm ready to go. So I love what I do. I don't mind taking patients all the way from the beginning of an end to a journey. I, of course, would much rather see them cured, would much rather take care of them in the long term and not have them suffer and die from their illness. But I also am prepared. I feel emotionally prepared to take that on when it happens. And then we have some real breakthroughs, especially for patients with a genetic alteration like BRCA. And that's very inspiring. And taking care of those patients then just pushes you forward.
Well, we thank you for that because we need more of that. And talking about that, what's the significance of the genetic mutation for the BRCA1, BRCA2? And this one I'm not familiar with. I don't know, the PALB2?
PALB2?
Yes.
PALB2. Yeah. These are three different genes all within the same sort of DNA damage repair pathway system. So BRCA1, 2, and then PALB2, which actually is very similar to BRCA2 in the way that it behaves, in the way that it causes the same types of diseases. It's just a lot more uncommon. That's why I haven't heard about it. It's rare, but it behaves very similarly. The connection is that all three of those genes lead to an increased, predisposition to pancreas cancer. Not the same risk though. BRCA2 is a higher risk gene, and PALB2 is a higher risk gene than BRCA1. BRCA1 causes pancreas cancer less of the time compared to the other two, but they're all three high risk genes. And the downside, right, is that those genes can give you a terrible disease. And one of the things that is being worked on at Penn and nationally and internationally is to try to find ways to screen effectively for cancer, especially pancreas cancer, in those high risk patients. So there's data for that. But on my end, in the oncology clinic, the significance is that the cancers that form from patients who have those genetic alterations are often much more sensitive to specific chemotherapies and targeted therapies. So the gene, I tell patients in clinic, it's a double-edged sword. It stinks, right? It gave you this problem, but now that you have this problem, your prognosis and your life expectancy is actually much better than someone who has sort of sporadic or random pancreatic cancer. So there's a little bit of a little bit of hope there.
A little bit of a plus side, I guess.
Yeah, a little bit of a plus side.
If you want to look, I mean, you got to look at the positive, right?
I mean, I would have to, right? And if those patients are then able to be put on an agent that keeps them well for years with no disease progression, then it was a huge win.
Exactly. How does the presence of these genes change the treatment for and the treatment approach for patients?
So nowadays with pancreas cancer, any patient who walks in the door with a disease gets genetic testing or should get genetic testing. There's a really, the guidelines are very consistent now about this, and the issues actually are trying to get the patients the genetic testing that they're supposed to get, but that is now the standard of care. So what that means is that if you have a patient with pancreatic cancer, if they don't know that, if they've never had testing, you should be able to identify that they have one of these genes. It changes the approach in a number of different ways. The chemotherapy that's most effective for BRCA or PALB2 related pancreatic cancer is what we call platinum-based chemotherapy. You may have heard, I'm sure you've heard of FOLFIRINOX, for example, that has oxaliplatin in it. That is a platinum-based drug. And then there's another regimen called cisplatin and gemcitabine, which is also highly effective in that patient population. So the key is to identify whether your patient has one of the, whether you have one of these mutations, because it means you will very plausibly respond very well to one of those drugs and probably shouldn't get a non-platinum regimen, say Gemabraxane, right? Gemcitabine nab-paclitaxel, which is very commonly used, but probably shouldn't be used in a BRCA or PALB2 patient as the first line of defense. The second reason that it changes the management of the disease itself is that we now have a class of drugs called PARP inhibitors, which have been shown to be effective in the treatment of pancreas cancer. There was a really big phase 3 international huge study run by Talia Golan, who is an Israeli researcher, where they took patients with just BRCA, related pancreas cancer, treated them with platinum-based therapy for a number of months, and if they had no evidence of progression, took the chemo away and put them on this pill or a placebo in this particular design. And it showed that for some people, not everybody, but for some people, can get months or years out of that pill. We did a similar study at University of Pennsylvania that mirrored that result and included patients with PALB2. So now that's in the guidelines as well, that those patients can get PARP inhibitors. And then the last way that it might change the treatment of the disease is in the curative intent setting. So somebody who does come in with an early stage cancer, if they're able to get operated on and have the cancer removed and they finish all their treatment, we now have a national clinical trial running of PARP inhibitor as an add-on to that. So after you finish all your treatment, you get your surgery, you get your, whatever it is that your doctor thinks you need, those patients now have an opportunity to enter a trial where they might get a PARP inhibitor to try to prevent the disease from coming back. So there are a lot of ways in which knowing you have this alteration could actually really change the course of your disease.
Yeah, and I didn't realize this was used like for the reoccurrence, because for pancreatic cancer there is such a high reoccurrence. And
Yeah.
do we know why that is? Why is there such a high reoccurrence of it? I mean, you can go for years with nothing and then suddenly it pops back up again.
Yeah, so you're absolutely right. The study that established our current guideline for the standard of care, which is surgery and then 6 months of the FOLFIRINOX combination somewhere mixed in with that surgery. How to order it exactly is unclear, but 6 months of FOLFIRINOX and a surgery is the standard of care for that cure rate. And even in that study, which was groundbreaking, and for us was the best result we've seen in the curative intent setting, roughly 60 to 70% of patients will ultimately have a recurrence. Most of those happen in the first 2 years, most of them. And then the curve sort of flattens out a little, but you're absolutely right. People can recur even years later. And for that reason, we watch them very closely. The reason we think that even when we see a lesion just on the pancreas and take it out and treat that person, the reason we think those recurrences are so common is that it's probably the case that even when on imaging, the pancreas cancer is only in the pancreas, it's very plausibly already systemic somewhere out in the system already, even at that time. And so that recurrence rate, we suspect as a field, reflects, at least in part, that phenomenon, that even when we don't know it's there, it's already kind of floating around. It's just really sneaky. And so one of the pushes to try to help improve those outcomes is to try to move some of the chemotherapy actually before the surgery, so that you are kind of cleaning up theoretically that microscopic metastatic disease before you hit the surgical time point. There's again also a national study by a researcher called Christina Ferrone. She's a surgeon. trying to address that exact question and kind of put that issue to bed, if that will help people live longer, if we give them some of the chemo up front and sort of kill off some of that metastatic disease that we can't see before taking them to the operating room. But it's devastating, it's devastating in the clinic. Somebody goes through a Whipple, which is a bear of a surgery. It's a hard, really difficult recovery for many people. Their digestive system is forever, changed. And then to, 2 months later, come into the office to have their scan and talk about curative intent treatment and then have new liver lesions. I mean, it's something we need to do better. We need to figure this out better.
Yeah, it's a difficult cancer, and I've known a lot of survivors have gotten, a number of years and thought they were, out of the woods then, and then to have it come back. So it's something.
It's not fair.
No,
Not fair.
it's not, and something like you say, we really need to try to work better and see what we can find.
Yeah.
Do you know, and I don't know if this is by patient, but I know some doctors do chemo first and then surgery, and some do surgery and then chemo. Can you kind of talk about that a little bit?
Yeah, absolutely. It's all very controversial. We don't have the answer. That's the answer. We don't have the answer. We literally don't have the answer. We are working on it, right? So there's the traditional model, I think from days of old, with surgery and then 6 months of chemo. And there were a number of small studies that sort of showed that potentially giving chemotherapy, some of the chemotherapy or all of the chemotherapy up front before the surgery might be beneficial, as we were just talking about. And so we really don't have definitive data yet to tell us what the right answer is. Again, that study that's ongoing hopefully will address that because it's a big randomized trial. But right now, you're exactly right. It is patient by patient. It has to do with a lot of different factors, including what the patient wants, what the tumor is doing. So is the tumor removable today, or does it have some contact with one of the local vessels and we want to pull it away from a vessel? It has to do with other features of the tumor itself. Is there going to be a problem if the tumor is not removed immediately, like a blockage or something? Are we forced to take the tumor out first, for example? And then sometimes it has to do with diagnosis too, that sometimes, pancreas cancer, you may know, is sometimes hard to diagnose. You can do several biopsies and sometimes not get it. And so in those cases, we have long discussions, surgeon and med-onc, and to try and figure out what the right answer is. My own practice is I prefer to give some of it up front if I can, and if I can get a patient through it well and their tumor is stable and their markers are stable, I try to give them the whole thing up front. And the reason that I do that is a couple of different things. One is I don't want someone to have to go through chemotherapy if I can avoid it after a Whipple. We know that it is much harder on the system. Once your digestive system's been rerouted, to then have to get FOLFIRINOX for 6 months is right. You just made a face. That's exactly the face. The face is, you've already lost weight. You're already miserable. And then the doctor's going to give you chemo. So I try to get it in up front because sometimes it's simply easier. We know people will get more chemo if we do it up front. The second is that often I'm trying to shrink the tumor, or, in cases where it's not exactly resectable at the moment we meet the person, we're trying to get them to that point where a surgeon is comfortable, where they think they can get the whole thing out and get all the margins clean and all that. So sometimes we're doing it for that reason. And then the last is this micro metastatic disease phenomenon, where I would rather try to sweep that clean a little bit before somebody needs a 2-month break to recover from their surgery, just out of fear that they've got metastatic disease. So the way that we approach it at Penn, or the way that I approach it, is that it's a very, very close collaboration with our surgeons. And we take the patient and we kind of do 2-month intervals, as I'm like, okay, I can't hurt you too much with the chemo because you're gonna have to go through a big surgery. So let's watch your weight really closely and your protein levels closely. And every 2 months when you get imaging, we're going to review it with the surgeon again and say, where are we and what should be our next move? Can you take any more? Do you need to go to the operating room now, or can you finish it out? So it is right now, because we don't have data to tell us, the answer. It's very much case by case basis. And I suspect that most of us are practicing that way now, where we sort of do the best we can and use the data for the patient in front of us to try to inform the decision.
Yeah, that face was made because I was on that for a little bit. So
Right.
that was the face. And, the hope, like you say, was to draw the tumor away. Mine likes to shrink back into it for some reason. It doesn't want to quite let go. So it wants to kind of hang in there. But
That's very rude. Very
I
rude.
know, right? You think I must be a really good host. I have to do something, I think, to change that so it doesn't want to hang
Too
around me.
nice.
Well, I maybe in some ways. Now, your study involves switching the patients from the infused chemotherapy to is it PARP? Is that how you say it? Or is it PARP-E? Okay.
PARP inhibitor. Yeah, PARP.
Okay. What has been
PARP.
the impact of the switch on the patient's quality of life?
So this is truly the most wonderful thing that I've ever gotten to do in my career was that study so far. Maybe there'll be some more good stuff, but um, just unbelievable. So these patients had to have, at least 4 months of chemo, no evidence that their tumor was growing. So they were, in other words, they were responding to the platinum therapy, which is really important because tumors that have progressed on or have become resistant to platinum typically don't respond to PARP inhibitors. So you don't want to try a PARP inhibitor if the tumor is actively growing or demonstrating growth while on a platinum drug. So we took them off their chemo and put them on this oral agent, rucaparib, which is one of the many PARP inhibitors that exists. And the first thing that I noticed on this study was that people were willing to do it. And that was already, and willing to come from really far away to do it. So patients came to Philly from Mexico, France, Seattle, Washington, North Carolina, like it was really nuts. They would rather fly to me once a month to get this drug than to stay on their chemo. And that already was very, very moving. Because, imagine you have, and you know how to imagine easily, you have a disease that everybody says is going to kill you, right? You have a disease that everyone says is fatal. You're on a therapy that's actively working for you, and you are willing to leave that and go to an experimental drug. And what that taught me, or what that was, just sort of hit home, was how hard chemotherapy is, and that perpetually being stuck on perpetual chemo is so taxing and difficult and really just not a way to be able to live well. So that was the first thing. And then we those patients came, we took them off their chemotherapy, we put them on this pill. Everybody got the pill in our study. It was not a placebo study. Everybody got the drug. And I mean, it's just incredible. I mean, it's like watching a flower bloom, kind of. But people, their symptoms got better. They have more energy. We spent more time talking about their traveling and their grandchildren and their children than we did about their symptoms. Not that PARP inhibitors are non-toxic. I don't mean to suggest that at all. They have toxicity. They can cause fatigue. They can cause diarrhea. They can cause nausea. They can cause joint pain and all sorts of things. But even with all that, compared to the chemo toxicities that these patients were on, for most of them, they would say, I would ask them, how does this compare? And they would say, it is not comparable. It is not comparable. So people traveled and did things they couldn't do. And, I presented the story at a conference, and some of the patients let me show pictures of them and the things they could do that they couldn't do while they were on chemo, like walk on a beach and go teach painting classes in France, and all these kinds of like crazy things. And it was just it's in some ways kind of just unreal how wonderful the quality of life was away from these cytotoxic drugs. And for some of them, it lasted for a long time, and it's still continuing to last. We still have 7 patients who've been on that study for over 4 years, and 4 of them have more than 5 years who've been on. They're still on it. They're just still stable. But we don't get that result for everybody, obviously. And so PARP inhibitors are a big start. They're a way to it's something that we can now build on to try to improve the outcomes even further.
Well, doing the infusions, which, I have done, just having to take the time to go, and it was rough, but even just some of the side effects. But then when I was able to take, I think it was Tarceva, the oral, it was just so much easier. You just,
Yeah.
and yes, there were some side effects, but they didn't seem to be as debilitating as the infusions were for whatever reason. So
There's a huge benefit to not being stuck in an infusion center for 4 hours, right? Or longer,
definitely, yes.
right? Every 2 weeks. Yeah, for sure. It makes life a little more normal.
And it just seemed like I said, it just seemed like the side effects were harder
Yeah.
with the infusions. I don't know if it's, if it's the makeup or what, but it just seemed to be harder. And so I was very happy to be able to try that, and it worked very well. You received a Career Development Award. Congratulations, to support your
Thank you.
research. Can you discuss how the funding is critical to advancing cancer research?
We can't do it without funding. That's the very simple answer. We literally cannot do it. Running trials is an expensive operation. Doing translational work in the lab, basic science bench work in the labs to understand more about the patients, more about their tumors is expensive. Where I actually recently got the Career Development Award was a number of years ago. I recently received a grant from the Lustgarten Foundation, which I'm sure you're familiar with, to run a maintenance trial, another maintenance trial. And we have 3 laboratories involved, 2 at Penn and 1 at Dana-Farber. And we want to know more about the immune microenvironment of these tumors and how they react to chemotherapy and what are their genetics on a cellular level. And there's so much you want to know. What are the peripheral blood cells? How do those play into the immune system and how that works? And you start racking up all the cost of all those things to be able to move the field forward, and it's just astronomical. It's just all really pricey, plus running the trial itself. So to be able to, as quickly as possible, move the field forward and understand most deeply what affects a patient and how that patient interacts with their treatment and how the cancer interacts with their treatment, we need funding. We have to have the time and the resources to be able to do the things that we want to, in order to help patients more quickly. And you kind of said it, right? The first thing you said is it's a bad disease, it's aggressive, it's bad. Like this is an emergency. We need to figure this out. And so career development awards, grants, NIH grants, foundation grants, philanthropy, all those pieces play into the puzzle of helping us be able to solve the problem in a speedier manner. That's the word.
I thank you for coming. I mean, the time goes by so fast, unfortunately, but really quickly, if you could, looking forward, how do you envision the treatment of pancreatic cancer evolving, and what makes you hopeful for the future developments?
I mean, the targeted therapies are coming. They're coming. Pancreas cancer with BRCA is rare. It's about 5 to 8% of our population, but there are other targets. There are other mutations in pancreas cancer that are now targetable. They're all rare, but they're all targetable. But what is really interesting and is really getting all of us very excited is that most pancreas cancers have a mutation in a gene called KRAS. That is not an inherited gene. That's only in the tumor. It's not something you get a blood genetic test for. But most tumors, over 90%, will have that. And it was considered the undruggable target. It was considered the thing that nobody would ever be able to crack. And a couple of years ago, somebody cracked it. And they made a drug for a specific KRAS mutation called KRAS G12C, which is relatively rare in pancreas cancer. But it was the proof of the principle that we could actually interfere with this mutation. And on the heels of that, there's now a tremendous amount of rapid work going on to target other KRAS mutations, including those that are the most common in pancreas cancer. So that, I think, if that works, if that plays out, then we suddenly have an incredibly targetable disease. And I think that may really change the entire ballgame.
Well, thank you for all you do for patients, and as a patient, I appreciate it. And, again, thank you very much. I really would love to have you come back because there's so much more. I mean, we could just keep going.
I know. Stay on for a while.
That's right. But unfortunately, we have other shows coming up after this. So, but I do really want to thank you for your time and for doing this. And as long as you speak my name, I shall live forever is dedicated to Jeffrey Ross from Laguna Beach. And I specify that because I realize we have a lot of Jeffrey Rosses, unfortunately, that have passed from pancreatic cancer. So, but again, thank you for being here and for talking. It was really educational, and I learned a lot as well. So thank you.
Oh, thank you so much for having me.
Well, there you have it. One more reason to tune in each and every time to Living Hope, a weekly journey designed to provide hope, inspiration, and education for those living with pancreatic cancer. Sharing the real-life stories of those really affected by this deadly disease and how they deal with it on a daily basis. And if you or someone you know is struggling with that right now, lots of places to go. We give them out all the time. Let's give a shout out to letswinpc.org. One of the many organizations spreading information like this today here about the real research taking place in this field. For all of us at OC Talk Radio, thanks for joining us. Hope you'll share this with somebody, and most of all, I hope you'll come back as we continue this weekly journey we call Living Hope.